Hey, let's talk about chest pain. I know this is a call that we're going to be on quite a bit, and so let's get really good at it. We're going to talk about how to assess a patient with chest pain, how to treat that patient with chest pain, and why that treatment is effective for these patients, okay? So, in the assessment, our primary assessment, I don't care who your patient is, this is a necessity. Those ABCs, guys, that's where we find the life-threatening stuff. So let's not skip it, all right? It takes 30 seconds. Airway, A, is it open? Okay. Breathing, B, is it adequate? So we're looking here for two things. I'm not counting respirations, guys. That's in vitals way later. I'm looking at what is the rate? Is it not normal, but is it adequate? So I'm kind of looking at between 10 and 30, right? If it fits in there, I'm not horribly worried. Then I'm looking at tidal volume. Are they moving enough air that you can see that chest rise and fall? If they can, and the rate is okay, right at the moment, I'm not worried about breathing. If the rate or the tidal volume are not okay, then we got to get moving and we got to fix that, all right? This video isn't about breathing, but if it's there, we got to fix it, okay? Now, you can slip in here if you want and do lung sounds and put the pulse oximetry on so it's ready to read later, but move on to circulation. Looking for bleeding. If there's massive bleeding, we got to get to fixing that early on, like first, okay? But right here, the thing I really want to look at on circulation is skin, okay? What does the skin look like? We know that patients that are not perfusing well, that are in shock, have pale, cool, clammy skin. I'm really looking for that. I'm looking for cyanosis, and I want to feel the pulses. If I have a radial pulse down here, I want to know, is it fast or slow, and is it regular or irregular? If I can feel the pulse clear down here, I'm not worried about the blood pressure at this moment, okay? Again, I'm not counting any of these. This is a quick down and dirty to find the life threats, okay? If your patient's chief complaint is chest pain, I'm assuming their airway's open because they're telling you that they have chest pain. So let's move on. Okay, let's move on to that secondary assessment. If we have taken care of all the ABCs, we're going to jump into that secondary because this is where we're going to figure out what's going on. Okay, so things we're going to do is we're going to look at that OPQRST. Those questions, along with the sample questions, are important. Every single one of them. Do them in order. Don't ever skip one, and you will become a really good, thorough technician, okay? Or clinician, I mean. If we start skipping around, you're going to miss something that's real important. So, onset. What were you doing when this started? Okay, that's important to know. There's a difference between somebody that's exerting themselves and somebody that's in bed and woken up with chest pain. That's two different situations, and you need to understand what you're dealing with. P is the next one, and that's a weird word, provocation. Okay, simply ask your patient here, does anything you do make this better or worse? Okay, because sometimes, like patients who, it gets better if they sit down and rest. Okay, if it gets better when they sit down and rest, we know they have stable angina. That's not nearly as bad as unstable angina, and it means that this is not quite as critical. We still need to hustle. We still need to get to the hospital, but it's not nearly as critical as if this pain doesn't go away. Okay. Q is quality. This is probably, in my opinion, one of the more important questions that you're going to ask your patient. It is also the one that most people get wrong very frequently, okay, in how they ask it. So this question is simple. Don't make it harder than it is. Ask your patient, repeat after me, okay? Tell me how this pain feels. And then be quiet and let them answer. Don't give them options. Don't say, is it sharp or dull? Is it stabbing? Is it nothing? You let them tell you so that you fully understand what they're feeling. If you give them choices, if you say, is it sharp or dull? And it's a tearing pain, it feels like something's ripping apart in their chest, that's a classic sign of a dissecting aorta. If you ask them to pick between dull and sharp, they're going to pick one of those, but you're never going to hear the tearing part to be able to make a good clinical decision. So don't go there, okay? How does this pain feel? Period. Okay. R is radiation. Again, that's one of those words, kind of like provocation. If you ask that, sometimes your patients are like, I don't understand what you're asking, and you're not going to get a good answer. So my favorite way of doing this, and I stole this from somebody, is ask your patient to take their finger and draw a circle around where the pain is. And then once they've done that, you've got a pretty good idea of what you're dealing with. Ask them, does the pain hurt? Is there pain anyplace else? And if so, draw a circle around that. And you'll find out where the pain is, and it's really simple for the patient to answer you. So go ahead and steal that and use it. You'll find it's very helpful. S, severity, okay? On a scale of, I use 0 to 10. To me, 1 infers that there's still pain. I want to give them the option of 0, there is no pain. 10 is the worst pain you can imagine. Where do we fall in there? Okay, we are consistently going to use this patient's pain scale throughout this entire event. The hospital will pick up on that and use their pain scale. So will the cardiologist. So we're going to start with that, and we're going to use that number, whether you think your patient's kind of wimpy or not, it doesn't matter because we're always using their scale. So we're going to consistently use that because what we want to use it for is to find out, is the pain getting better or worse? Are our treatments helping or not, right? So we're going to start with what is the pain on a scale of 0 to 10, and then T is time. When did this start? How long has this been going on? Now, in all of this, we're going to ask some clarifying questions. If you don't understand something or the patient answers you, but it spurs another question, then ask that question. We need to make sure that when the patient says, well, it got really bad about 15 minutes ago. Okay. When did it start, though? How long has this been going on? Is this the only time today you've had pain? How about in the last couple of weeks? Have you had any pain similar to this? Okay. Ask those questions. Then we're going to jump into sample history. These are going to be super important. Now, S is signs and symptoms. You've probably figured that out by this point in time. But A is allergies. We need to know that, okay? If we're going to give medications and you haven't asked allergies yet, shame on you, okay? I know you guys don't do that. So ask about allergies. M is medications. We have to know those. Things I'm specifically looking for right here. Do they take any blood thinners? Do they take a daily aspirin? Are they on any erectile dysfunction drugs? Do they take any medications that for their heart, any cardiac medications? They have cardiac history here. Okay, so dig into those medications and figure out what is it that they take. Also, ask about herbal medications. There's a herb out there. Now, I'm not an herbologist by any stretch of the imagination, but there's an herb out there. You can buy it in Walmart. It's called horny goatweed, and it does the same thing that Viagra does. And people take it. It's on the shelves for a reason. Okay, so ask about those things as well, because some of those herbal medications, I mean, all the medications that we have right now all come from plants, guys. Herbal medications come from plants, so they are important. They're not harmless. They're not always harmful by any means, but we need to know what your patient has on board. Okay. P is past medical history. So I'm going to ask about, do you see a doctor for anything? Have you been in the hospital in the last couple of years for anything? Have you had any surgeries? Do you take any medications? I'm going to bounce back to that medication real quick. What anything that keeps you from functioning normally during the day? Okay. Any medical conditions we need to know about? L then is last oral intake, which if they're having chest pain, may not be one of the more important questions you're going to ask, but it certainly will be for the surgeons when they get to the hospital. If they're going to go into the cath lab for a stent, they're going to need to know that. And then E is the events leading up to. What were you doing? That sort of falls into that onset of the OPQRST. But we're going to throw in here now risk factors. So some things I want to ask, more clarifying questions are, if you take medication, did you take them today? Okay. How much of it did you take? I want to know things like family history. Do you have a family history of cardiac issues in your family? If so, has anyone died from those? Brothers, sisters, cousins, mothers, all of that. Okay. Are you a smoker? Do you live with a smoker? Any chance you could be pregnant? Okay. I want to know, are you on birth control pills? That, for some people, presents a higher risk of pulmonary embolism. For females over the age of 30 that smoke, huge risk for pulmonary embolism, which causes chest pain. So those risk factors, do you exercise regularly? Do you take any like supplements to workout supplements, anything like that? I also really, in this day and age, I want to ask about energy drinks. Okay. Do you consume them? If so, how many? Have you had one today? Okay. Then we're going to jump into the physical assessment. Now, just because it's not a trauma patient does not mean this is hands off. It doesn't mean that at all. So start at the top. Now, we don't need to be palpating to see if they have a skull fracture, but I do want to look. I want to feel. I'm looking for JVD. I want to look at the eyes. I want to make sure that there's no jugular vein distension, which is a big sign of heart failure. I'm going to come down. I want to look at and I want to palpate the chest, okay? If I haven't listened to it, I want to listen to the chest right here as well. Take your hand and simply press on the chest and see if you can reproduce that pain by touching them. If you can, this is not a cardiac issue. I had a patient one time I touched, and when I got to the side, she pulled away and winced. And I'm like, that hurt? She's like, oh, really bad. Now, she had described her pain to me as a sharp stabbing pain, worst pain she's ever had in her life. So because I could reproduce that pain by touching it, I looked, she had a rash on the side of her chest. And unbeknownst to her, had developed shingles overnight. And extremely painful. But the way she described it to me was this sharp stabbing chest pain. She herself had not looked at the chest. She just knew it hurt. So do that. Don't skip palpating, listening, and looking at the chest. Now, while you're right there, go ahead and feel the abdomen. There's lots of important stuff in there too. So check out the abdomen, zip on down to the feet, and look for pedal edema, another big sign of heart failure. Okay. Now, up to this point, we have not taken vitals, and that's okay. If you've got a partner, they can certainly be working on that while you're getting through the questions that you've got. Things I really want to look at, I'm going to do all the vitals, but I want to make sure I have lung sounds. I want to look at the SpO2, and I want to get a blood pressure, okay? That skin is huge. If you have got pale, cool, clammy skin, you have a patient who is not perfusing well. We need to fix that. If your patient has pink, warm skin, they're perfusing fine. Their oxygen levels are good. Your SpO2 will help you evaluate where we're at in that. And then I want to take a blood pressure because there are some treatments that are going to be dependent on the blood pressure. So let's look at those. Okay. So once we've got some information, we can start, depending on how the patient describes his pain, what was leading up to it, we can start making some decisions on what we think could be causing the pain. If you think this pain is cardiac in origin, or there's a possibility that it is, we need to consider some possible treatments. First one is oxygen. This is the one that people go to be like, oh, geez, you're having a heart attack. 15 liters of oxygen, non-rebreather. My answer to that is hold your horses. No. Look at perfusion. If your patient is pink and warm, they do not need oxygen. And here's why I'm adamant about this. If I over-oxygenate my patient, I give them oxygen that they do not need, I'm going to cause vasoconstriction. If I have an artery, a coronary artery in the heart that is blocked, we call that a heart attack. If that's what's going on, and I make that vessel smaller, I'm completely blocking that coronary artery. I am going to make this heart attack worse. I could even kill my patient. Okay? Be smart. Oxygen is a medication. Treat it like that. Okay? Look and see if there's a need. I am consistently having people say, well, I'd give them 2 liters. My question is why? If they do not need oxygen, they do not need oxygen. Not even a little. All right? Now, if they need oxygen, by all means, give it to them. We never want to deny oxygen to somebody that needs it, but make a good decision. Our protocols right now are saying 94% and above are fine, right? A lot of hospitals have already made that move to, they're not worried about anything under 90. I mean, over 90, good Lord. Over 90, they're fine, all right? We're going to see oxygen go away a little more than what we've seen in the past. So in the case of cardiac, oxygen can be extremely harmful. Don't give it unless it's needed. The other thing we can think about is aspirin. Okay, a couple things we need to know. Are they allergic? And have they taken some today already? If they've taken a chewable aspirin, you may consider giving them 3 more. Okay. If they take it some days, but not today, they're getting aspirin. And here's why. Okay. You got to put up with my cheesy drawing. Sorry. Okay. So this little guy is a vessel, and the red arrow is the blood moving through the vessel. Okay. On a good day, things work great. If you're there for chest pain, maybe it isn't a good day. Okay. And what happens sometimes in these vessels is they build up with plaque. It's kind of the same plaque that the dentist picks off your teeth. It's rough, it's hard, and it builds up inside the vessels. And if that happens in the heart arteries, it makes the inside of that artery smaller. And if it builds up a lot, it can completely plug up that artery. So depending on how much of the artery is plugged is going to determine how much oxygen is getting through. We're going to start to see chest pain in our patients with plaque buildup or an occluded coronary artery once it gets enough that it's starting to keep the oxygen from being adequately delivered to those cells. Some of our patients that are working hard, their heart muscle is working harder and is going to require more oxygen. And that's why we develop chest pain. Sometimes when we're out really working is because the heart muscle is requiring more oxygen than can be delivered through this plugged up artery. Okay. So here's another thing that's going on inside that artery. And that's we've got little platelets. Those are the little blue things there. And we've got red blood cells moving through there. Now the platelets have a job, and their job, they're sort of like little Velcro creatures. Can you see the little legs on them? Okay. Their job is to float around in that artery, and they are feeling for irregularities or rough spots in the vessel. Typically, a rough spot in the vessel wall means that that vessel wall has been compromised, cut, or ruptured, in which case that platelet's going to grab onto that and hang on to that rough spot and start grabbing all of its buddies and pulling them in, and they're going to clot up to plug the hole. All right. Now the problem is plaque is also rough, so sometimes those platelets can pile up there. They get activated. They feel like there's a reason for them to clot up here, and they're going to start activating and clotting up, and they can take that narrowed artery and completely close it off by forming a blood clot right there. Okay. What aspirin is going to do is it slickens up those platelets. It's an awful lot like grabbing a can of spray Pam and putting it in your skillet before you fry your egg so that this egg doesn't stick. Okay. It's like putting Pam on the platelets. Okay. They get slickened up and they can't hang on to things anymore, which means they can't clot up, which means they can't make that artery more occluded, more closed off than it already is. So it will definitely help. It will keep it from getting worse for sure. However, aspirin takes a little while to work, okay? Because it's chewable. We're going to give it to them. They're going to chew it. They're going to swallow it. That's not a real quick acting route for medication. So get that on early and just make sure that you don't have any contraindications. Make sure they're not allergic or they don't have clotting issues that they take other medication for. Now, be noted, we do not give aspirin for pain relief, okay? If we're going to give something for pain, we're going to pull out a bigger gun than that. And it's going to require ALS, but we're going to give them fentanyl or morphine to relieve that pain, not something as simple as aspirin. Aspirin is for the platelets, okay? The other thing we're going to consider is nitroglycerin. Now, nitroglycerin, if you have a patient that's prescribed nitroglycerin, they probably know that they have some heart issues or they wouldn't have that medication with them. But some things, if we're going to give nitro, whether it's the patient's nitro, whether it's nitro that you have on your own squad, that varies from state to state and department to department. But before we consider nitro, we want to know a couple of things. We want to know, A, what is the blood pressure? Okay, nitro is going to make that vessel bigger, as you can see right there. If we make that vessel bigger, it's going to open up the opening in the middle of the vessel and it's going to allow red blood cells to get through there easier. That is going to relieve the pain, because what the pain is are those cardiac cells that are not getting enough oxygen. Now, cardiac cells are kind of high maintenance, very much prima donnas. And when anything doesn't go quite right, they start screaming out and raising holy heck. Okay? That is what chest pain is, are those cells saying, we got to have more oxygen. They're actually dying without the oxygen. So if we can take that vessel and make it bigger, we're going to open up the middle channel in that vessel and allow more red blood cells to go through. That is going to fix the problem temporarily, okay? It's going to buy that patient some time to get them to the hospital and get this taken care of effectively long term, okay? So with nitro, though, a couple things I need to know. If my patient doesn't have a blood pressure of, most departments say 100 systolic, some will go 90, but because we know those vessels are going to dilate, then we also know that's going to drop the blood pressure. So if we can't make sure that we're going to maintain an adequate blood pressure to move the blood flow, then nitro would be dangerous, so we won't give it. The other thing I do want to know is, are they taking erectile dysfunction drugs? And the 3 drugs I'm looking at for that right now are Levitra, Cialis, and Viagra. Okay, if they've taken those in the last 24 to 48 hours, that is dilated vessels in their extremities, and we're going to turn around and dilate the vessels centrally in the chest and the heart. That could drop the blood pressure so low with both of those on board at the same time that we're not going to get the blood pressure back up. That could be disastrous. Okay, so I'm asking about that. I'm checking a blood pressure. Okay, if we can give those 2 medications are working on the same problem, but they're working at it from 2 different angles. I don't want to give one and not the other unless there's a real good reason why I'm not. Aspirin will work on the platelet issue. Nitroglycerin works on the size of the vessel issue. Together, oofda, good treatment plan. Separately, not so much. Okay, if you can give them together with chest pain, do it. Okay, just make sure there's no contraindications. If you can only give one, then give the ones you can. All right, moving on, we can consider ALS. It's chest pain. I don't know which way this patient's going to go, but chest pain is always serious. We're always going to treat it seriously until we have reason to believe otherwise. All right. The other thing we can do, if you have the capability, is getting a 12-lead EKG and getting that sent off to the ER so the physicians can get a pretty good eyeball on what's going on, and they're ready for that. When you come rolling in, they know exactly what they're taking care of. Okay. All right. Couple wrap-up points. Oxygen can be harmful. Just because your patient's having chest pain does not, it used to, it does not anymore mean that they get high flow oxygen without question. We will give oxygen when needed and no other time. The other take-home point from this is nitro and aspirin are our dynamic duo. They should be given together every time that we can do that in a patient that has cardiac chest pain. All right, guys, I love spending time with you. Thanks for putting up with me. Have a great night.